keep not only a medical side but also the social and personal side, which is also an important element of quality. Thank you.
Dr. Nadkarni.
I urge Dr. Indu Bhushan to increase the incentives after their analytics come out.
Paula.
I think that in order to make it work, this whole scheme work from a government perspective, yeah, there we go. I think one of the things we've learned in the United States is that you can use the leverage of being the public sector, being the government. You're the big guy, and you have a lot of levers and you have a lot of power to help in implementation of a never-event payment policy. So certain extreme mistakes, like giving a patient the wrong blood type in a transfusion, the federal government through its payer, and the federal government in the United States pays for about half of health hospital costs today, but they will not pay for certain types of events like that. And that really creates an incentive for the providers to be focused on those types of events. So there are ways certainly that the government, because of your great power and influence, can help with that.
Ms. Sangeeta, how can technology help in ensuring that quality is incentivized as a part of the Universal program?
So, Dr. Hariprasad, I think yesterday you all had a great debate on technology and touch. I think the framework for quality actually starts first with the people, the quality of the people and the training. So here I'm for the touch bit. So all of you, quality starts with you, and that's something that all of us have learned. But just looking at that framework for quality, I think it's very important to work at multiple levels. Number one is the human resources. Number two is role clarity, accreditation, upskilling of these human resources. Number three is continuous monitoring, where technology is going to play a very, very important role. And then shifting of the onus of the tracking, not just on the number of procedures and the amount of payment, but beginning a comprehensive, transparent outcomes reporting system. And I think that's been one of the big needs of the country. All of us have seen the move of the quality journey from being an infrastructure tracking to a process tracking to an outcomes tracking. I know it's a difficult and a complex subject, but the beginning of this wave and this focus on quality, or the next dimension of quality assessment, will happen when we have a national outcomes reporting system. And I think that's where the crux of many of these things lie. But I also believe that we need an adequate coverage system so that the healthcare systems are not forced to take shortcuts on quality. Because cutting too much in terms of quality of material, shortage of manpower, not replacing equipment on time, many of these things also can hamper quality. So as you all know, it's a complex subject, and I really thank Dr. Bhushan for saying that that we are partners in this journey, and we're very happy to share any thoughts on framework.
Taking it on from there, there's a common belief that low cost means low quality. How true is that, and what's your opinion? Paula and Dr. Harish can respond to that.
That's a very complicated topic, because sometimes to have good quality, there are costs associated with that. But the other balancing factor, obviously, is bad quality can be extremely expensive, both to the patient and to the provider. So it's very difficult for me to give you one broad answer there. But usually there are investments that you have to do from a quality perspective to make sure you have the right processes in place in order to manage the risk of healthcare. So, but if you keep up with those types of things over time and you practice good quality care, you will make back those investments, but not in the immediate future. But I think before you do the final analysis, you really need to understand what does it cost when you make a mistake. As I said, in the States now, to the extent certain mistakes are happening, no one's paying for those. Insurers are not paying for them, and the government isn't. So that has created an incentive for better quality. But there is a level of proficiency in terms of skills of the staff There is a level of equipment and a facility that you need to have in order to really protect the patient, particularly when you're doing high-end complex procedures, that it's, I think, naive to say that that can be done at a really low cost as well. I think that you need to do this on a scenario basis in terms of who's doing what services and what does it really need to do those services in the way of equipment and particularly people in order to do it well. So I think we need to have a realistic approach to what the actual costs of quality are. And there are investments associated with that that you need to do to assure a certain degree of quality.
Before Dr. Harish speaks, Dr. Narottam has something to say.
I was just wanting to point out what Paula was saying. If there is a low cost, if you compromise on quality, you rightly pointed out that there is going to be a huge cost to pay. A classic example that is visible in the aviation industry today is the grounding of the Boeing MAX plane.
Yes.
It has not only cost Boeing in enormous losses, I think in billions and trillions of dollars, but it has cost the aviation industry a 34% loss. Nobody's booking planes. The same thing happened with the Pratt & Whitney engine for the Airbus. So it's not only that low cost will result in low quality, but also that the cost of that low quality will be a very huge price to pay later.
And I just want to add one thing, though, on the other side of it, because there are certain practices in a high-quality performing organization that do save money. And Dr. Bhushan referred to some of this. Standardization definitely improves quality and does save money. So things like that, where processes are the same over and over again. When you purchase equipment in a way that reduces the risk to the patient because it's the same in every part of a building, across a system, across a country, which is another place that the government can be influential. So standardization not only creates a safer environment for the patient, but also a lower cost over time to the provider. So I could argue ways that quality and things like accreditation do help reduce costs.
Dr. Harish?
I would agree to say that a certain amount requires to be spent when you want good quality. But you must remember that it's not possible to make every person perfect, but it is necessary to make system perfect. The best of the sparklers, best of the fuel pumps don't make best of the car. It is how well they are working together that matters. And therefore a huge amount spent on individual and less amount spent on systems doesn't get you benefits. It is always acceptable quality level in industry. In healthcare, we said perfection. Though we have to aim at perfection, you must understand limitations of changing systems. So standardization forms an integral part of any quality system, but changing environments definitely put stress on that continued standardization. I would say that the Deming's 14 principles still are greatly relevant, in which there is an atmosphere of fearlessness and pride that worker takes in working are some of the principles. I think they bring out quality of organization strongly. Then we try to make every person perfect.
Ms. Sangeeta had something to say.
I got a very good comment from one of our team members in the audience, so I want to share that. And Dr. Sai, he's over there. So he basically said that, and if you can get a mic, grab it, Dr. Sai. He says we can maintain quality and reduce costs using technology. He runs the EICU. So go ahead, Sai, take the mic.
Thank you for the opportunity. So I think what we're talking about is transformational. I think it's a privileged moment we will all remember in history that today, September 14, we actually had this conversation, because 10 years from now, when we look back, we will say the journey began today. What I'm talking about is critical care is probably one of the most expensive parts of healthcare. And it is probably the most stressful for families, patients, systems. And if you look at the cost of care, a large bulk of that goes into critical care. What is a secret that most patients don't know is the cost of critical care is actually not a lot if you can implement very simple measures. A simple example, I was on call last night, I saw a patient with low blood pressure. All it took was to give him IV fluids at a very rapid rate within 15 minutes. Now that is a concept that is foreign to most providers. You don't give fluids that fast, but evidence has shown that you can actually save lives doing that. That information was transmitted by our team to a center 12 hours by road in the middle of the forest in a small hospital in a public sector industry. That patient's life got saved. Simple knowledge transfer like this is actually happening within India. We also do this for other countries. And if we can actually implement this on a large scale, we'll save lives, and that one patient did not have to transit 12 hours by road with 7 family members missing their work, school, education. And a simple measure like this can be implemented right away. So I would urge the people who make decisions to think about this as an opportunity to transform care right now, today.
The next question, which Anupam will take it on, is does accreditation, whether NABH, JCI, NABL, whatever, really impact the patient care and quality? Does it really happen? Or is it just a certificate that hospitals work towards? Anupam will make a comment and then we'll hear from
Thank you, eminent panel for your comments, and thank you, Hari. To answer this question, I'm going to actually ask the audience, and we did this yesterday. How many of you are from accredited hospitals? Show of hands, please. So, we have about 45-50% accredited. Now, I want to ask you, has accreditation made a difference to your hospital? Is it safer? Show of hands. So, virtually all the hands go up, and that kind of answers that question. Our chairman had asked us to start looking at accreditation in 2003, and we went to Chicago after a global search and looked at Joint Commission as the gold standard, and our hospital in Delhi was the first to be accredited in India and the 6th in Asia. And then NABH has done a phenomenal amount of work, and today accreditation is well established in India. But let's pause for a moment and actually do a dipstick. There are only 34 JCI accredited hospitals in India as of 1st of September and 634 NABH accredited hospitals as of 1st of September. How many hospitals do we have? Upwards of 25,000. So actually, accreditation has a long way to go. And there are several reasons why hospitals are hesitant. They believe it's a huge investment. They believe the leadership has to work extra to be able to get a hospital accredited. But as has been discussed over and over since yesterday, there are numerous benefits that accreditation brings. So for the 55% of the audience that hasn't gone down the journey of accreditation, please think about it. But having said that, there is more to quality improvement than accreditation. For example, I think the lessons we learned with establishing the Apollo Standards for Clinical Care and the Apollo Quality Program, I think has started to show dividends. The fact that we actually put our outcomes on our website and have been doing that for several years shows that there is more to quality that an institution can do beyond accreditation. And I think, as Ms. Sangeeta alluded to, the patient safety declaration that we want each one of you to sign and really become a part of this movement is really about going back to your hospital and asking yourself this question: what is it that I can do today that I didn't do yesterday to make my hospital safe? What is it that I can do to empower the housekeeping workers, the nurses, the dietitian, the technicians? And how is it that everyone can speak up when they see something that doesn't seem right, doesn't feel right, is not right based on evidence and knowledge that we have? How can that stop? So it's about empowerment, it's about being proactive. And I want to just ask one last question to everyone. We've been doing this for 8 years. When Ms. Sangeeta conceived of this, it was a handful of us. Now we have 2,800 people. I want to ask you this question. Do you feel more energized, more passionate about patient safety today than you did 2 days ago? Show of hands, please. Great. Thank you so much. Over to you, Hari.
Actually, we were doing a review yesterday, and 7 or 8 of our hospitals are Joint Commission accredited, and the remaining are all NABH accredited. So we probably have the highest number of accredited hospitals in the country, either Joint Commission or NABH. But sometimes the organizations will say that they don't get the opportunity to get accredited within a specific period of time. It takes a much longer time, especially with NABH, because they don't get dates for inspection, they don't get dates for survey. It takes a very long time. So what do we do to scale it up to reach the level which Anupam was talking about?
Do you want my answer?
Yeah.
One of the things that we have noticed is organizations start counting time from the day they register, not when they have complied. And we have found that after they comply, we recently had a case where hospital applied and is accredited within a matter of 8 months, undergoing pre-assessment, final assessment, closures, everything. So if organization is prepared well and then applied, then it works well. If you apply and then go and purchase the standard and then start looking at it, implementing accreditation is a multi-departmental activity. And many of the activities as a project management, I consider it pretty complex. Because you have to simultaneously work with various departments, and the people who are carrying out work rarely have the authority to enforce what they are asking people to do. They are just facilitators, and therefore the organization structure, their commitment, the expertise of the people, everything matters. So if they comply with the requirements, the process is fast. But if they start counting, I mean, it's like when you go to hospital and stand in the OPD line and see the time doctor sees you. It's different, and you start counting the time when you enter the gate of the building and start counting the time doctor sees you, including the car parking time. Then the things really go wrong. And we do this study regularly of how much time it is taking. It is taking longer in entry level because of sudden load, but accreditation system is going absolutely well.
That's reassuring, Doctor.
Thank you.
Hari, I think we have in the audience the Vice Chairman of Joint Commission, Dato.
Really insightful discussions. Thank you so much, panelists. One quick question. Yesterday, we heard many CEOs from companies like Microsoft, Roche Diagnostics, and the discussion was that the healthcare of future will become personalized. It will be very customized to each human body, each type, and this is what we hear from doctors and surgeons today also, that each patient is different. But at the same time, we also talk about standardization because that's important for feasibility and sustainability. So are these opposing principles? Because we are, looking 10 years ahead and we feel that there's going to be more personalization, but today we are moving towards standardization. So any comments on that?
This question was, you're not talking about standardization, yet saying healthcare will get personalized. So what is your comment? Those two things can be integrated. The standardization that I refer to is often about the process of delivering care, or the process of doing a procedure, or the process of admitting a patient. So the fact that we're talking about a more digitized personal care environment, there is still a process associated with how that type of care would be rendered. So standardizing there, I understand that the personalized care means you're at the DNA level of the patient almost in some instances. But the process of delivering the care is where the standardization has the impact and advantage. So I think they still work as an integrated pair in terms of personalized care, standardized care. They don't discount each other, they actually enhance each other.
Hi.
And personalization itself will become a standard.
Hi, I'm Srini. This question is to Dr. Indubhushan. In the US and UK, there is one system of medicine, and it's easy to, rather than saying easy, it's okay to try standardizing treatment guidelines and other initiatives. But with a country like India, with 5 different system of medicines being used, and patient has the right to, at any point of time, go to any of these systems, then how do we, try achieving standardization? For example, a patient who has cancer put in the middle of the treatment, move from one system of medicine to another. So what kind of guidelines can be put in such situations, and how Ayushman Bharat, being a national level initiative, try to address such issues?
Frankly, I don't understand the question. So are you saying that in India it's not possible to put standard treatment guidelines for
I'm curious about it because the large scale of population, because if you see 30 to 40% of population in many of the rural areas would want to still access traditional system of medicine many a times. And when we bring an initiative like this, in the US it's managed care organizations which just don't talk only reimbursements, they also involve in seeing whether standard practices are being met. But in India, if a patient chooses to say, move away from one system to another system, and if they are not planned in our guidelines, how do we then address it?
Currently, we are not looking at alternative systems of medicine. We are just, we don't have Ayush or other systems that we are covering. So we are sticking to only the what we call modern medicine. So I believe STGs should be fairly straightforward for those, right?
Yeah. And this is specifically for Dr. Harish. Are you accrediting the non-allopathic hospitals like the Ayurveda and the rest of them? And what are your plans?
Very much. There is accreditation standard for Ayush hospitals, Panchakarma clinics, and it is very much a proper standardized accreditation like allopathy. They have their own technical committees of each one of them, homeopathy, yoga, naturopathy. So it is already there. Also, just because those systems are Indian doesn't mean they cannot have standardized treatment guidelines. I am aware that Ayush Ministry is working heavily on the scientific aspect of the traditional medicines and trying to create a national database on various outcomes, etc. So work is going on there.
Yeah, thank you, Doctor. And there are a large number of nurses in the gathering here. And on behalf of them, I want to ask a question. There are a lot of changes which are coming about with the new NMC and new regulations that are coming out. Right now, nurses are not allowed to prescribe medications, and they have specific privileges as far as nursing is concerned. Now, with these changes which are coming about, will they be allowed to prescribe medications? Will they be able to provide care with telemedicine or remote health care? What's the thinking of the government on that aspect?
And also in terms of the ambiguity on prescribing via telemedicine. And I know we have a great authority in the audience also, Mr. J. Satyanarayana. We're very happy that you're here. And we acknowledge the tremendous work which you have done in terms of creating the National Digital Health Blueprint. So, if you would like to also comment on prescribing via telemedicine. But back to you.
Well, this is something probably I can't comment on because it's a policy issue and not dealt with by us. But I have a feeling that as the technologies change and evolve, I think our laws will have to also follow them, and there's always a lag, but hopefully we'll have some resolution on this soon.
But on behalf of all the nurses sitting here, I would like to request you to carry back this message and to the right people.
Thanks.
And we have the Vice President of JCI here. Look forward to his comments.
I think, thank you, Dr. Hari Prasad. We talk a lot about what we can do and policies and all that, but what has impressed me and the environment I work in is, again, going back to telling stories. I remember at one of the recent board meetings in Chicago, Paula, correct me if I'm wrong. The president of the Joint Commission International, Dr. Mark Chessin, made a comment. Mark Chessin of the Joint Commission made a comment that in the US, every week, was it 45 wrong site surgeries? And when I tell this to people, 45 wrong site surgeries every week, and the reaction when I tell people this is, wow, such a lot. But what I tell everyone is, do we know how many wrong site surgeries we have in our environment? Because we don't measure. We might sweep it under the carpet, it might not be done. But then systems like timeout and all help us to prevent this. And another story which I tell, I say all these stories because when I talk to people, these are the things they remember, not the policies, not the standards. One other comment which I have said here before is that I went to the Royal Infirmary in Edinburgh, the temple of surgery and where they teach people how to do surgery. And as you walk into the lobby, there is a showcase in one corner, and in that is a preserved lake. And underneath there is an inscription which says, I removed the wrong leg. I hope you don't make the same mistake. And this is the way through which surgeons, orthopedic surgeons and many others walk through. So this was written by a world famous orthopedic surgeon who treats, or rather who teaches students into orthopedics. So I believe that we need to do a lot of storytelling, and I remember in this very conference which I really enjoy and admire, talking about another patient who was injured. Her name is Alicia Cole, and showing a video. And I think these are things we should hold on to and shout out, and that might convince more people to get on to getting accredited. Thank you.
Thank you. And the last question, and she's very passionate about it.
Myself Neha. My question is to Indu sir. In rare diseases portfolio, when we see patient number is less, but the cost of care is very high, and it could be any disease, we have patients struggling with it. So within the aegis of Ayushman Bharat, what is our plan of action or even thought process around it? One. Secondly, around decentralized cancer care model, preventive promotive becomes very important components. Then the next level is the specialty care. The oncosurgeon comes much later in the process. So how are we planning to strengthen the preventive promotive part of it at the village level, where especially the doctors are scarce, the nurses are less, and the demands are high? Thank you.
Well, that's a very pertinent question, and I've asked that question very frequently. Ayushman Bharat has two legs. One is that you hear about very frequently, which is the Pradhan Mantri Jan Arogya Yojana, which is focused on secondary and tertiary care. And then there's another leg, which is the health and wellness centers. And so the aim and vision is to develop 150,000 health and wellness centers, and they will focus on preventive, promotive and follow-up care, and so strengthening them so that they can provide the kind of services that you mentioned is extremely important. And you're right that without that kind of support, one, the burden or the load on secondary and tertiary care will be very high, and secondly, there's a saying that prevention is better than cure. Probably is much more efficient to just focus on prevention and promotion first. So it's a combination of both that one has to look at. Both legs of Ayushman Bharat, which jointly will work on this. And as you can realize that putting together 150,000 health and wellness centers is not an easy task, and that's why it has been staggered for over the next 4 years, and out of 150,000, 20,000 health and wellness centers, about 10% have been put in place, and we are on track to establish them by 2022. So with that, probably we hope that we have this comprehensive system of healthcare.
Thank you so much. It's been wonderful, great session. I would like to specifically thank the panelists there on the dais, and let's give them a big round of applause.
Ladies and gentlemen, signing the patient safety declaration can also be done using your mobile by clicking on the link which shall be displayed up in the front. Go to the declaration page and sign up using your registration number. Maybe can we have the display up in the front, please? Collect your lunch coupon from the registration desk if you haven't still done it. Get more information on our Patient Safety Club and enroll today for the latest updates and happenings in the field of patient safety and quality. Do spare time to see the e-posters. Visit Quality Stall to know of more about quality systems and processes. You can download the International Health Dialogue app to know the latest happenings of the conferences and activities. Your certificates will be available digitally on your app. Please take selfies at the selfie booth. Please give feedback for the conference on the app. Participate in the lucky draw and win exciting prizes. Ladies and gentlemen, let's continue a conversation over coffee. Be a part of speaking circles to hear expert views of patient safety topics in the same hall. We have with us Dr. Sahana Govindaya, Associate Director of Medical Services, Apollo Hospital, Bangalore, talking about overcoming challenges in clinical pathway implementation. As more interesting sessions are in store, we request you all to reassemble back at 11:45 sharp for interesting sessions. I beg your pardon, by 11:30 for an interesting session, the media affect what patients want. Thank you.
Hello. Hi, good morning. I know you're on a well-deserved coffee break.
Welcome to
We are here.
range for the last 10 years.
So we are here in this corner discussing clinical pathways. So please do join me for a discussion on clinical pathways and the importance of following clinical pathways and what are the difficulties that you face.
In any case, I'm happy I was born there. We had a wonderful village. Not so big those days. My father was well respected in the village and as a village head. Every bit of it, the people who moved with us, sharing and happiness, that is the type that village had, a wonderful atmosphere. Anyway, I grew up, thanks to my parents, allowed me to get education and then become a doctor. They supported me to go abroad. So when I was abroad, we write letters to your parents, right? I sent a picture, the letter came, and I opened that letter. Normally, the manager will write, so and so conveys, but this time he wrote himself and said, whatever you do, there are two people who enjoy it, meaning my mom and him. If you do something back home, how will that be? He didn't say come back. But the meaning was very clear. I thought to myself, saying, what do I do for the place where I was born? So first I thought, let me eliminate that one thing which all others did not have, and five of us, me and my brothers and cousins had, by having this teacher come and teach English. Second thing I thought, we are in the business, I'm saying, we are doing so much for people, not only for our country, more than 150 countries people are coming to us. That's the time once I thought to myself, that we must make a difference to the health of people for our village. I said, now why not look at the health for this whole mandal, which is 39 villages, 69,000 people, from birth to the last breath.
నాకు 400 ఉంది షుగర్. సార్ చెప్పినట్టు టాబ్లెట్స్ వాడుతా ఉన్నాము. ఇప్పుడు 180 కూర్చున్నది.
బాలింతలకి కానీ గర్భిణీ స్త్రీలకు కానీ పౌష్టికాహారం లభిస్తూ ఉంది. కడుపులో బిడ్డకు కానీ ఎటువంటి ప్రాబ్లం లేదు. 15 days once వచ్చి చెకప్ చేస్తున్నారు. కానీ ఇంతకుముందు మాకు వీళ్ళు రాకముందు బస్సు సౌకర్యం లేదు సార్. వెళ్ళాలంటే కానీ 1 hour పడుతుంది చిత్తూరుకి.
In many ways, we have structured it very nicely. If they come to Chennai, Hyderabad, or Delhi, you got checked, you got about the same checkups were done by them. And through more modern methods, 36 million people will die annually from the so-called NCDs. What are these NCDs? We have diabetic capital of the world, heart capital of the world, cancer capital of the world. Even if you multiply it 10 times over, our healthcare system, we can't match it. What we can, only way we can prevent is to do a war on NCDs. So this is why I said we must do for them total health, which is trying to give for the 69,000 people physical health, mental health, spiritual health, ecological health, and holistic health.
హాస్పిటల్ వారి సహకారంతో పంచాయతీ వాళ్ళు ఇక్కడ ప్లాంట్ నిర్మించడం జరిగింది. ప్రజలు ఈ నీళ్లు లేకముందు థైరాయిడ్, జాండీసు, వైరల్ ఫీవర్ లాంటి సమస్యలతో బాధపడుతున్నారు. నాకు బ్యాక్ పెయిన్ ఎక్కువగా ఉండేది. నేను ఏ పని చేయలేకపోయేదాన్ని. ఎన్నోసార్లు డాక్టర్ దగ్గరికి పోయాను, ఏ మాత్రం తగ్గలేదు. కానీ ఇక్కడ వచ్చే కంపెనీ వాళ్ళు మాకు యోగాలు నేర్పించారు. కొన్ని చిన్న చిన్న యోగా సూత్రం వల్ల నాకు ఆ బ్యాక్ పెయిన్ పూర్తిగా కంప్లీట్గా తగ్గింది. దాదాపు 200 members నేర్చుకున్నారు. 100 members వచ్చి ఆల్రెడీ వాళ్ళ కాళ్ళ మీద వాళ్ళు నిలబడగలుగుతున్నారు. తన పర్సనల్ ఖర్చులు కూడా కానీ హస్బెండ్ పైన ఆధారపడకుండా తను సంపాదించుకున్న దానిపైన కష్టపడి తీర్చుకోగలిగే శక్తి కల్పించినందుకు శతాబ్దికి నా ధన్యవాదాలు.
What I am telling our government and our country and the world is, I believe that we should now give a totally different meaning to health. So this is where I started a program for the country and for the world. What's called Life is Priceless. Something like that, I think we need to bring that type of a social revolution. Health is not just medicines. Health is to give total happiness.
Smile on the face. What does it take for a smile on the face? All it takes is a heart that can beat for you. That can be for you. That can touch your heart. Creating
Hello, ladies and gentlemen, may I please invite medical heads and quality heads to this corner of the hall because I want to discuss clinical pathways and its difficulties. Some of you who have been practicing clinical pathways in the hospital. Now, I have been speaking to a lot of doctors yesterday and last evening too. And some of the things that I have gathered is they have difficulty in implementing this successfully on the ground because of the buy-in or lack of it per se from the doctors. So I wanted to understand if all of you are having the same problem and if we can talk about it to see how best we can conquer these problems. So can I please invite some medical heads and quality heads to this corner of the room, please?